Welcome to the Near Miss Maternal Mortality Flip Classroom session. In this presentation, we will cover clinical scenarios that have been associated with maternal mortality and high-yield tips to minimize those events. This presentation is largely derived from information in the accompanying article that has been provided, entitled Saving Mothers' Lives, Reviewing Maternal Deaths to Make Motherhood Safer, 2006 to 2008, the 8th Report on Confidential Inquiries into Maternal Deaths in the United Kingdom. The objectives of this presentation are to review etiologic factors related to maternal mortality, to outline the top 10 recommendations to reduce maternal mortality, and to generate action items to assess institutional readiness. A review of maternal deaths in the United Kingdom between 2006 and 2008 identified clinical factors that were either directly or indirectly associated with maternal mortality. Several pregnancy-related factors were recognized as having a direct link to maternal mortality, including thrombosis and thromboembolism, preeclampsia and eclampsia, hemorrhage, amniotic fluid embolism, deaths in pregnancy, sepsis, and anesthesia. Pregnancy-related factors were also identified as having an indirect relation to maternal mortality, including underlying cardiac disease or psychiatric diseases. Finally, some factors unrelated to pregnancy were found to be associated with maternal deaths, such as coincidental causes like trauma or motor vehicle accidents, as well as domestic abuse. A focus on these etiologic factors would be the basis of a strategic approach to address the causes of maternal mortality. As a result of the inquiry into maternal deaths in the United Kingdom, a list of top 10 recommendations were formulated to address areas of weakness and reduce maternal mortality rates. These items are listed in no particular order, but rather are derived from an analysis of specific cases of maternal mortality over the 3-year period from 2006 to 2008. These top 10 recommendations include pre-pregnancy counseling, professional interpretation services, communications and referrals, multidisciplinary specialist care, clinical skills and training, specialist clinical care, systolic hypertension treatment, genital tract infection and sepsis, serious incident reporting and maternal deaths, and pathology. Pre-pregnancy counseling should be strongly encouraged, especially for those women with pre-existing medical conditions. Women with pre-existing medical conditions within childbearing age should be proactively offered advice about planning for pregnancy and the need to seek pre-pregnancy counseling whenever possible. Prior to pregnancy, these women should have a prospective plan for the management of a pregnancy developed by clinicians with knowledge of their condition and the implications for pregnancy management. Common conditions that require pre-pregnancy counseling and advice can include epilepsy, diabetes, asthma, cardiac disease, autoimmune disease, renal or liver disease, obesity, psychiatric illness, and infectious diseases such as HIV. In addition to these medical comorbidities, Other conditions that may impact maternal or fetal safety during pregnancy should be addressed in a pre-pregnancy counseling session. Professional interpretation services should be provided for all pregnant women who do not speak English. The presence of relatives or others that the patient interacts with socially can inhibit the free transfer of information, especially regarding sensitive health issues or domestic partner violence. Professional interpretation services are essential to fostering the autonomy of your non-English speaking patients. An independent, reliable interpreter is the best way to ensure patient confidentiality and communication of threatening situations. It is not appropriate for a child to translate intimate details about his or her mother, and it's unfair to both the mother and the child. Without the use of an independent interpreter, it's not clear how much correct information you may be receiving, or the grasp of the local language that the family member may have. And in some cases, the translator that accompanies the patient may also be the perpetrator of domestic abuse, so the woman will be unable to ask for help. Frequent and clear communication between providers involved in a pregnant woman's care is essential to ensure that problems are addressed in a timely manner. Referrals to specialist services in pregnancy should be prioritized as urgent. Trainee doctors and midwives should have a low threshold for upwards referral and must receive an immediate response. And good communication among professionals is essential regardless of whether a patient is classified as high risk or low risk. The use of protocols to guide which patient comorbidities need specialist consultation will result in less variability in the provision of care. Women whose pregnancies are complicated by underlying pre-existing medical or mental health conditions should be referred to appropriate specialist centers of expertise, where both their medical condition as well as their obstetric care can be taken care of. Providers should consider developing protocols to specify which medical conditions mandate at least a consultation in early pregnancy. Confirmation of clinical training and skill sets must be prioritized, with remediation of any providers that are not able to meet local standards. All clinical staff must undertake regular written, documented, and audited training for the identification and initial management of serious obstetric, medical, or mental health conditions. An example includes maintenance of basic and advanced life support skills such as BLS and ACLS. The onset of critical illness at any time during pregnancy should lead to the involvement and/or management of the patient by a team of specialists. Critical illness can be screened for by the use of routine screening protocols or checklists for all pregnant or postpartum women who become unwell to aid in the timely recognition, treatment, and referral of women who develop a critical illness during or after pregnancy. The management of pregnant or postpartum women with acute severe illness requires a team approach, often including help from anesthesia or critical care colleagues. Pregnant or recently delivered women with unexplained pain severe enough to require opiate analgesia requires urgent review by the attending. The guidelines surrounding the management of hypertension, one of the most common obstetric complications, must be adhered to uniformly. All pregnant women with preeclampsia and a systolic blood pressure of over 160 millimeters mercury require antihypertensive treatment. Consideration should also be given to initiating treatment if the overall clinical picture suggests rapid deterioration. Specific local projects should be devised to audit management and treatment of severe preeclampsia. Awareness and prevention of infection or sepsis should be a core principle taught to all providers and patients. All pregnant and recently delivered women need to be informed of the risks and signs and symptoms of genital tract infection and how to prevent its transmission. All healthcare professionals who care for pregnant and recently delivered women should be aware of the signs and symptoms of sepsis in the women they care for and the need for urgent assessment and treatment. Finally, high-dose intravenous broad-spectrum antibiotic therapy should be started as early as possible, as immediate antibiotic treatment may be life-saving. All maternal deaths must be subject to a high-quality local review. The results of these reviews must be disseminated and discussed with all maternity staff and their recommendations implemented and audited at regular intervals. The review and critical analysis of maternal deaths is a vital part of process improvement of obstetric services. A similar review of near-miss maternal mortality would further improve safety processes and reduce adverse outcomes. Finally, pathology is a critical partner in understanding the events that led to a maternal death. The standards of the maternal autopsy must be improved. The numbers of locations where they are performed should be focused in on the presence of specialized pathologists who will have a special interest in performing this service. More clinical discretion over reporting maternal deaths to coroners is required, and there should be complementary major input by clinicians into obtaining more consented hospital autopsies. Now that we have covered the top 10 recommendations for the prevention of maternal mortality, the question is how to implement these suggestions. One approach is to create benchmarks that can be audited and compared between clinical sites within an institution, or even between institutions. For each of the top 10 recommendations, we have provided examples of auditable standards. These standards, or variations of them, may be implemented at your home institution. Pre-pregnancy counseling. The number and percentage of pregnant women with pre-existing medical conditions for whom specialist preconception counseling is offered may be quantified. Professional interpretation services. A local audit may occur of the numbers and percentages of pregnant women who require and subsequently use professional interpretation services per visit. Communications and referrals. Local guidelines or protocols which have been developed to clarify communication and escalation upwards referral procedures should be available. Waiting times before being seen after a woman has been referred for a specialist opinion should be collected and audited. Multidisciplinary specialist care. Evidence of protocols should be present in specialist centers which specify which pregnant women with pre-existing or new medical disorders should be referred for consultant obstetrician assessment. Clinical skills and training. The percentage of clinical staff that have completed BLS and ACLS training should be tracked. The percentage of rapid response teams that can locate the maternity unit and have immediate access codes should be reviewed. Specialist clinical care. There should be evidence of protocols to screen pregnant or postpartum women for the development of acute severe illness. Systolic hypertension requiring treatment. Protocols for the management and treatment of severe preeclampsia should be disseminated within your local group. A review of cases where the protocol was not adhered to should be undertaken. Genital tract infection or sepsis. The percentage of women who have had an infection and who have had antibiotic therapy started within an hour of presumed diagnosis should be tracked. serious incident reporting, and maternal deaths. Every maternal death should be critically reviewed as a serious incident, and the lessons learned should be actively disseminated to all clinical staff, risk managers, and administrators. Pathology. A review of the quality of maternal autopsies performed and their proportion of all maternal deaths should be tracked. In summary, maternal mortality is a multifaceted problem that requires a holistic approach. This holistic approach includes the need to have buy-in from all obstetric provider levels, ancillary services, and the health system. The protocols need to be developed to guide clinical actions and reduce variability in the provision of care. Critical review of near-miss and maternal mortality cases should lead to further process improvement. The reduction in near-miss maternal mortality is a long-term goal that will occur through changes in the practice and culture of medicine. Thank you for listening to this presentation from the Near-Miss Maternal Mortality Flipped Classroom session.